Helen, can everyone see it kind of thing?
Yeah.
Perfect. Okay. So I know that you get great teaching on fluid management, and I know everything's different, and I know in surgery we can be different as well. Most of you who've worked with me will know how I operate. I like things to be interactive. I know MS Teams doesn't allow for that. And look, I'm not going to put anyone on the spot. If you want to answer a question, feel free. Okay. This is about a learning environment for all of us. And you'll see as I go through my next slide how integral I feel that your roles are to our department. So I've put a slide on here because I wanted to set the scene, really, because I wanted you to realize just why I give up my time, because actually one of you basically gave up your time when I was a baby doctor and I was an F1. I think you're all really highly skilled and very capable individuals. And actually, when I'm on call, I value your input to me so much. And most of you will know, I just say to you, bypass the F1 and the SHO, just bleep me directly, because that's how highly I think I value you, essentially. So I treat all of you at the level of a senior core trainee, and that may concern or shock some of you, but I don't think so, because I've worked alongside you, and the only difference that they have over yourselves is actually you've got more experience. You've got a lot more experience. To be a senior core trainee, it's 4 years post-medical school, and the majority of you have got all of that in abundance. Some people, where I was previously in Chesterfield, a lot of people felt that ACPs are just an A to E. That's all you do. And actually, I think that's completely wrong. And that's selling you all short, because I know that you do so much more. And when I present this, I'm presenting this because I want more of you, because I know that that's there. So you are all capable of interpreting these complex patients, but it's all pretty much the same. Okay, same framework. And I put this up because when you learn how to drive, before you start your car and stuff like that, you have to check your mirrors. And in medicine and healthcare, your mirrors, your foundation before you can even get going, is basically anatomy and physiology. And for those of you who know me, you may know that I've got quite severe dyslexia. I failed a year at med school. I really struggled with some of my multiple choice exams. And the reason I share that with you is because I really only learn what I need to know. So I wouldn't take a textbook and be able to go through all of that. I just take the bits that really apply to me. And that's what I'm going to try and put into this presentation. And as I said, I learned from ACPs. So when I was on nights, I learned a lot of my skill set from ACPs. And that's why I always make the effort, whichever hospital I go to get to know all of you, because I'm giving back to what I learned. So with all of that being said, and I'm through that, okay, I'm going to talk to you about fluids, and I'm going to talk about the extravascular and intravascular space, osmosis, osmolality. Please don't get panicked about any of these terms, because I'm going to break them all down. IV fluids, which you'll have a really good idea, aims with fluids, and then I'm going to talk about colorectal nomenclature, anatomy, colorectal surgery, some of the complications, and then at any point we'll go from there and we'll recap throughout all of that. So the intravascular and extravascular space. Essentially, the intravascular space is like a blood vessel. Okay, so this here, I hope you can see my mouse moving. Inside here is the intravascular space. When you give someone a fluid, you want it to remain in the intravascular space. However, blood vessels, although they are continuous, they're semi-permeable, which means that they can leak a little bit. So fluid can go out and fluid can come in. So outside the vessel is extravascular. And those two components are really important. So when you give a fluid, you want that fluid to stay in the intravascular space, because that way, that's going to go back to the heart. That's going to raise your blood pressure. It's going to stabilize your heart rate. So when you think of your sepsis 6, you're always thinking about getting fluid into that intravascular space. And all of you will know with your sepsis 6 that actually sepsis makes your blood vessels leaky. That's why your blood pressure drops. Because you've got the leaky vessels, because of all the bacterial toxins, these start to leak out into the extravascular space. And that's how people end up dying from dehydration. So with that being said, talking about osmosis. So osmosis is the movement of water down a concentration gradient. Okay, so I'm just going to put that into pictures because I'm not good with just simply the words. So if you look here at this diagram, essentially we've got water, which is here, and the water is the blue stuff, not the molecules. Ignore the molecules for the time being. If you counted up the molecules on the left-hand side, you can see there are 20 in total. On the right-hand side, there are 24, okay? So there are 24 molecules, which essentially is taking up the space here. So water, through a semi-permeable membrane, similar to how we were talking about in the previous slide, water will move from an area where there's more water to less water. And you can see that because there are less molecules on this side and there's more molecules on this side, there's actually more water on here than there is here. So that's what happens. It moves from here to end up here. And that's a really important content, because the more water in a fluid, the more pure water in a fluid, the more chance that has of, if I go back to the previous slide, of leaking out into the extravascular space, which is not what we want. There's another term that you need to know, and that's called osmolality. Now, osmolality is essentially the concentration of a fluid, okay? Or a fluid, as I said. So if you look here in this diagram, if you imagine squash, I'm someone who likes really strong squash, okay, and that's represented in the yellow here. But some people like weak squash. Now, for the same amount, so if that's 500 mils of fluid, if this is all 500 mils, I hope you can appreciate that the more the concentration increases, so the more that there's other stuff in it, there's less water, okay? And if something has a high concentration, so it's got loads of sodium chloride, loads of potassium, it means that it's got a high osmolality. And a high osmolality, if we go all the way back, basically means there's more chance of it staying within the vessel. Because if you had a low osmolality, it means that you've got more water content. Water's going to go from a high area of concentration of water to a low area of concentration, so it's going to leak out. So just so that we can crystallize that a little bit more. If you look at your fluid composition, if you look at your blood, your plasma, we all know this because all of you will look up blood results and see sodium, potassium. Obviously in our trust it's 5.2, that's the higher end on the potassium, but these are pretty much regular. But if you look, there's a range of the osmolality, 280 to 295. So anything that is above this value will likely has more chance of staying in the intravascular space, okay? Anything below this basically means that it's got more water in. It's dilute, like the weak squash I was talking about here. So if we now look at sodium chloride, sodium 154 millimoles, they're big molecules, okay, which means that there's less water in. And you can see as a fluid, actually sodium chloride has some very positive reasons for giving it. That's one of the reasons why we give it in resuscitation, because what we're trying to do is keep the fluid within the vessel. Dextrose, however, now I know on medical wards people love dextrose, but dextrose literally is water and a bit of glucose. And as you can see here, it's represented in the fact that its concentration, the things that are dissolved in it, it's only glucose. So it's only 250. So the chances are, if you put this into someone's body and you try to do this, 250 stat, for example, the chances are you're just going to make them really edematous because it has a very low osmolality. Hartmann's, that a lot of us like in surgery, it's a good fluid, but you can see its osmolality isn't amazing. But what it does have is it's got bicarbonate, and it's in the form of lactate, which is a buffer. So if you notice when you get your blood gases, you notice that people are acidotic. Essentially, when you give them Hartmann's, you're giving them something to balance the base. And that's what it does. So it balances the acid by adding base. In other trusts that I've worked in, what people like to give is dexsaline. And again, the reason being it's got a bit of sugar for nutrition, but actually it's got a good osmolality. And the last thing is plasmolite, which we don't give in our trust here, but they do give it in Barnsley, and that's probably one of the best fluids you can give. And again, it's got a base, but in the form of acetate. And so that kind of neutralizes what happens in sepsis when you get that acidosis. And again, you can see it's got a high osmolality. Now, sodium chloride, dextrose, and dexsaline, you can make into a better fluid by adding to the concentration, okay? You can add potassium to these. So a lot of the times that you'll see a prescription from me, you will see that in the acute phase, I'll give either sodium chloride, Hartmann's, or Plasmolite, because ultimately I want to get volume into the patient. But if I'm then trying to resuscitate them afterwards, I tend to add potassium. Obviously, you've got to be careful about not giving 20 millimoles over an hour. You want to spread that out over 4 hours, for example. But that's part of the reason that when you give a fluid, it's not just, oh, I just give Hartmann's because it's surgery. It's about the appropriate reason. And in surgery, every time I give a fluid, I want it to stay in the intravascular space. The sicker someone is, the more septic they are, it doesn't matter how high your osmolality is, how high the concentration of the fluid is, they're going to leak a little bit, okay? But you've got more chance of it staying intravascularly. So in terms of fluid aims in surgery, what the NICE guidance shows is that it's 1 millimole per kilo. Now, for someone like me, I'm like 90 kilos. You're never going to give me 90 millimoles in a day, okay? You're most likely going to give me 40 to 60. And for maintenance, if I was nil by mouth, you kind of, I use the principles of if you're 50 kilos or less, I go 1 to 2 liters per day, which is the equivalent of 12 to 16 hourly, and 20 millimoles of potassium for the day. With someone who's greater than 50 kilos, I kind of go with 40 millimoles that I'm trying to balance out with 2 to 3 liters. Obviously, in surgical patients, a lot of them are sick. So one of the prescriptions I do like is I like to see some potassium, assuming that actually the bloods are normal, the potassium's reasonable. But it goes to, but people who get panicked about giving potassium and they go, actually, oh, look, the potassium's like 4.9, I can't give them 20 millimoles. Well, actually, if they're not eating and drinking and the person's 50 kilos, you giving them 20 millimoles, actually their potassium levels should actually come down even lower because they need 50. So you're actually really safe. And that's what I'd probably say to people is that the thing I like about potassium is it helps stimulate the bowel. So in things like small bowel obstruction, I want a nice potassium level of like about 4.5 or so. So I just want to have a quick recap of what I've just gone through, because that will build on the colorectal bits that I'm going to talk about next. So consider when you give fluids, you want higher concentrated fluids, more stuff in it. And if you're not sure, and if you've kind of forgotten, and you know all of my ramblings have kind of lost you, on the back of the fluid charts actually has a similar table to the one that I showed you before that has the osmolalities. And essentially, the higher the osmolality, the less water there is, which means that that's not going to leak out into the extravascular space. So higher concentrated fluids for acutely unwell patients. Adding potassium will increase your osmolality because, as I said, osmolality is about the concentration of that fluid. Again, you're looking at 1 millimole per kilo every 24 hours. But again, feel confident in prescribing potassium. Even if it's 5.1, for example, still feel confident about giving potassium. If someone's kidneys are working, and I'm assuming their creatinine is normal, then you can give it because the kidney will just exchange that. And then, as I said, Hartmann's and Plasmolite, sometimes you'll hear this term that, you know, you'll hear doctors saying, oh, it's physiological. That's not because it's got potassium and it's got other things in it. It's mainly because it's got that buffer solution in it. So that lactate, that acetate, it works like bicarbonate. It neutralizes the acidosis. So just before I go any further, can I just check whether there are any questions about everything that I've said? And I apologize if I've kind of just, you feel like I'm teaching you to suck eggs, but let me know what you think. Tell me if there's anything. If there's nothing, I can move on.
Yeah, there's nothing in the chat, G.
Fine. Okay, so let's move on to colorectal surgical complications. So I think this is really poorly taught, not just to people like myself, okay, because I'm always having to read this out of a textbook, but actually to junior doctors. And even for some of the colorectal nurses, it can be really challenging because the formalized teaching isn't the best. So again, when you go to see a patient who's had a colorectal procedure, I'm a big believer in not reading the notes. The only thing that you really need is to know whether a patient has an allergy to an antibiotic. Because ultimately, when you go to assess a patient from A to E, it's all about stabilizing that patient. And for a lot of the courses that we go on, and if you see any of my documentation for me reviewing a patient, it will say like ask to see patient news 8, for example, but it will start with A, B, C, D, E. And that's exactly how I've seen the patient, because I could spend time looking at the notes, but that's not going to get me any closer to treating that patient instantly. And if that patient's septic, we all know we're going to need blood cultures, fluids, morphine for pain relief, antibiotics. These are all things that we would delay. So my first thing here is don't read the notes, assess the patient, A to E. That's what I want from everyone, basically. And I say that to all my juniors, and they really get a hard time from me, and they always get frustrated because a lot of us love to look up SCR, know everything about the background, but actually stabilize that patient, recognize whether they're sick or whether they're well, or how urgent you have to action things. The next thing is that once they're stable, then actually go and look at the notes. Have a look at the background, see whether there's anything that you think could be contributing to this. And the most important thing is actually that A to E. And if they need antibiotics, despite the temperature, even those of you who end up on Firth 9, those HBV patients, they've been cultured like 3 or 4 times, culture them again. Every time they spike, culture them. And you may think, oh, that's just a waste of time. But one of the things I learned with being in the hospital is actually on a Wednesday afternoon, we actually have a microbiology ward round for the HBV patients. They grow some really weird and wonderful things. And actually, sometimes they have 4 or 5 cultures despite being pyrexial with a temperature, but their cultures are negative, and it's that 5th one that grows something. And that's the thing that changes lives. So I know it's frustrating, I know it's extra hassle, but cultures are so important, and there's nothing wrong with giving someone a shot of antibiotics. You can't ever go back in time to give people antibiotics, but you can give them right then and there to save lives. And then read the operation note. And I think this is the thing that when I was more junior, I used to read an operation note and I never used to understand it. And that's because I never really had I never was in the operation, but I didn't really have the basics. Like how I started, and I was saying, actually, it's all about checking your mirrors before you start. There are just a few basics that I'm going to talk about first, so then we can talk about some of those complications. So, nomenclature, okay? So essentially, some of you may have children, okay? And some of you in your family, like my sister, she likes the letter J. So every single one of their kids, like all the boys, have J's in their name, okay? And they're biblical as well, because that's what she likes. Now, in medicine, there is a structure to naming things. And if you know that structure, it applies to everything. And that's where I think that the best place to start is. So, ectomy means the removal of something, okay? Col is short for colon. So colectomy is removing colon. Hemi is half. So if I said a left hemicolectomy, I'm removing the left part of the colon to about halfway. Subtotal basically means the majority. So if I said a subtotal colectomy, it means that I'm removing the majority of the colon. Procto, so people think that the colon includes the rectum and the anus. It doesn't. That's why it's colorectal. So the colon kind of goes all the way from the right side all the way down to the sigmoid. And then at the rectum and the anus, which is like the right bottom part where you push out, that's referred to as procto. So if you had someone who had a proctectomy, they would have had their rectum and their anus removed, but the rest of the colon could still be there. And pan means everything, right? So if you said pan procto, so that's all of the rectum, all of the anus, and I said col for colon and then ectomy, that pan proctocolectomy means that all the colon, all the rectum and the anus, that's what's removed. With that being said, I just want to show a little bit of anatomy, okay? And for colorectal, all you need to know is that all of these multiple loops here, you've got your duodenum, you've got 3 meters of small intestine, okay? The end part of the small intestine, so the first part's the duodenum, straight from the stomach. This yellow stuff is called jejunum. And then the final bit, the bit that we're interested in when we're talking about this talk, is the ileum. So the ileum, you can see all of these loops, and then the ileum goes in to the first part of the colon, which is the cecum, and then you see this appendix down here. So I just wanted to show that for now. Now, an anastomosis. What is an anastomosis? So an anastomosis is basically a connection. It's a join between 2 structures. So in colorectal surgery, we tend to cut things out and plumb them back together. Now, you can imagine that there are going to be risks involved in that, and there are going to be issues, patient issues, so patient factors, as well as surgical factors. And the one thing I would say to you is, you may know me, and you may know other trainees, and you may know other consultants, but I always say that assume that everyone makes mistakes, because you know what, we all make mistakes. So don't think that someone's really good and they wouldn't make a mistake, because actually there are the mistakes that you know right away. And when you read an op note, every time I read an op note now, I kind of know when someone's wasn't 100% on the way they did that operation. And you can tell it when you read it. And the more op notes you read, you'll know. Basically, don't trust anything. And that's the best way to be with a patient. And that's why I say, don't read the notes. If you read the notes, it colors you completely. If you go and see that patient, you straight away, right at the edge of the bed, you're like, this is a sick patient. Okay, I need help. And that's what you need with this. So an anastomosis is a join. So colorectal operations. A right hemicolectomy, as you can see, so this bit is going to be our ileum, end of the small intestine, essentially takes out the right side. So takes off about half. I know it's less than half here. It normally is a bit less than half, but right hemi being half, col for colon, right hemicolectomy. And what you tend to do is you join this part of this, the large intestine, the colon, with the ileum. That's your anastomosis. You join those 2 bits because you've removed this. An extended right hemicolectomy, that is when you go a little bit further along this part of the colon. And again, you anastomose this part of the colon, again, to the ileum. And that's why in the previous slides, I wanted to show you the ileum. There are different reasons that this can be done for. So when you're looking at that operation note, look at the indication. Was it a cancer? Was it for inflammatory bowel disease? If it was for inflammatory bowel disease, that could mean that the patient's on steroids or immunosuppressants. In surgery, we hate immunosuppressants because it prevents healing, which basically means that my beautiful join is at risk of failing. And then a cecal volvulus. So this part of the bowel, it's the most floppy part. It's called the cecum. So as soon as it enters into, from the terminal ileum into the large bowel, this first part is called the cecum. And sometimes that twists on itself. And I've got a picture of that. So you can see here, in some patients, it's really floppy. If it twists on itself, it becomes ischemic, no blood supply. And ultimately, the treatment is normally a right hemicolectomy, because you have to kind of remove this and then you join it together. That way the plumbing is still kept intact. Moving on. So now we go to the other side. So we talked about the right side here. This is more the left side. So this is a sigmoid colectomy. So this part of the bowel right towards the end is called a sigmoid. And again, ectomy, removal, sigmoid colectomy. A left hemicolectomy doesn't always take the sigmoid. So sometimes it's just taking this left side. And again, the join would be from this part of the bowel. So it's basically colon to colon. With the sigmoid colectomy, it tends to be colon to this part, which is the rectum and anus. And as I said to you, the rectum and anus structurally is different to the colon. It's all part, but we all talk about it as one of the same thing. So a low anterior resection and a high anterior resection. Okay, so these are normally done for cancers, and a low anterior resection is when that cancer is in the rectum. So I've got a little picture here. So basically all of this is kind of rectum. And you can see this little bit here in the pink. Basically for a low rectal cancer, you want to get a clear margin. So you remove this part of the rectum, and you also remove higher up. So you've got a clear margin. So the cancer is free. And what you then do is you anastomose this part of the left colon down to the rectum. Now, you may be thinking to yourself, you know, why'd you do that? Like, what's the difference? The rectum and your anus, when you go to do a poo, okay, when you defecate and you describe this motion to patients, anyone who suffered from constipation, when you try to pass a motion, there's that squeezing process. So you'll sit and you'll squeeze. And some people, it can take them 30 minutes and they'll describe it to you. That squeezing process is because you've got sphincters that basically allow your anus to squeeze. Now, you don't actually defecate when you squeeze. You actually defecate when you relax, because it squeezes down, and then the internal sphincters right down in your anus, which you can't really see here, but imagine just a little bit more of a tube here. That's where you actually end up allowing control of your bowel motion. So if you didn't have your anus and you didn't have like the end of your rectum, then you can't control your bowels. It would just fall out of you. So that's why you do a low anterior resection to try to keep people from having a stoma for life. But you can see that you're joining right here onto right here. So if you damage any of the function of these sphincters, you can get some real complications where people are just leaking constantly. A high anterior resection removes again the sigmoid, but it's higher up. So these operations, these two in particular, because they're involving the rectum and you're anastomosing to the rectum, they're very high risk for the actual anastomosis, the join, for failing. And that's something that I just kind of want you to keep in mind, because when you read that operation note, it will start making alarm bells start sounding. Now, subtotal colectomy, I said subtotal means the majority, and it's normally starting from the right-hand side. So you remove the majority of the colon. This part, as we said before, is the sigmoid. This is where you get your diverticular disease mostly. And you join essentially right from the terminal ileum, so small intestine, to colon. Again, you can see that when you start taking away the colon and you start anastomosing, there's a short distance for the patient's stool to go. So your bowel, your large bowel, absorbs 90% of the water that's left in your body. That's what makes the stool firmer. So if you drink lots of water, your stool will be softer and more liquid-like. Now, these patients suffer from constipation. So not from constipation, but they suffer from actually being leaking and having lots of diarrhea. And you can understand why, because you've lost all of this bowel. But on the upside, they don't have a stoma. So a total colectomy is when you remove everything, including the sigmoid, but you leave the procto part, the rectum and the anus. So again, these patients don't need a stoma. An abdominoperineal resection, or an AP resection, that's normally when you've got a cancer right at the anus. So you can't really get away from it. People who have cancers really low down, and when you do an internal examination of the bottom, it's really low down. They can't get away with it, because you have to remove that part to get them the oncological clearance to cure them of their cancer. But it means that you remove the sphincters. So these patients who've had an abdominoperineal resection, they can't have a true anastomosis. They'll end up having a colostomy. So here at this point will be pulled out as a colostomy. So if you see an abdominoperineal resection, you know that patient doesn't have a bottom. It's sewn up. We suture the anus. There's no point because it's got no function to it. A total proctocolectomy, again, same thing. Sometimes patients with ulcerative colitis, a form of inflammatory bowel disease, sometimes their colon is so toxic, so swollen that we have to remove the whole thing. And sometimes these patients are only 17, 18 years old. So that's a lifelong stoma that you're going to end up giving that patient. And again, you'll just end in this scenario, you'll just pull out an ileostomy because it's the ileum. So you'll bring that out as a stoma. So those are kind of like the majority of the colorectal cancer type operations that you've got. Before I go on any further to talk about the complications from these operations, does anyone have any questions about how I possibly have described certain operations and whether they make sense? And it's okay, we're both learning. So actually, if you tell me that I've not explained something, I'm very happy to try and explain it in a different way. Helen, is there anyone? Or just tumbleweed? Am I just that good?
No, you did that.
I'll assume I'm just that good. Thanks, Ed. I needed that. Okay. Right. So moving on. So I think that one of the first complications, it's not really a complication, but it's more of a presentation. And the reason I say this is ileus. Okay. I expect the bowel doesn't like to be touched. And when I describe this to a patient and they go, what is ileus? I say, look, the bowel doesn't like to be touched. When it gets touched and handled, or when there's pressure on it. So if you put a laparoscope and you blow up air into the abdomen, you're putting pressure. It's almost like you're handling the bowel. The bowel doesn't like it and it just goes on strike. So what normally happens is you eat food, it gets into your small intestine, and your small intestine does this. It peristyles, it squeezes it along, but it just goes on strike. So it just stops. So everything just kind of pulls, and sometimes it pulls all the way down to the rectum and the anus. So sometimes, I know some of you don't necessarily feel comfortable all the time doing PR examinations, but sometimes actually I advocate this because sometimes all it is that at this point here, the sphincters are at the bottom. They literally just have water, okay, because they haven't been able to form hard stool, and all they basically need is a little bit of pressure to kind of release that to allow more of the liquid to come out. But ileus is essentially a deceleration in intestinal motility. I think my explanation is better, but that's the gold standard if you're in an exam. It's just the slowing down of the gut. So it can be a sign of something that I'm going to talk about next, an anastomotic leak. So ileus shouldn't be assumed that it's definitely ileus. I want you to rule out other things before you say it's ileus. And that's why you have to manage this appropriately. So risk factors. So you look at this patient, which you've already done with your A2E. Increasing age means they're at higher risk of ileus. Electrolytes that are all over the place, they need to be corrected because, again, I mentioned to you before, the bowel, especially the colon, it likes potassium. So if you're low in potassium, it's really common that you just don't get that contractility. And that's what you need. You need that intestinal contractility to get the bowels going. So neurological disorders, that kind of goes hand in hand because the way we communicate, the way our bowel communicates is via the nervous system. So if you've got a neurological disorder that slows the nerve endings down, then you're going to be at more risk. Opioids, well, we all know that, look, they constipate patients, and that again slows motility down. Pelvic surgery. So pretty much any one of the operations that we spoke about here, you have to get right down into the pelvis. And when you're playing around with the pelvis, anything involving the rectum, when you're playing around in that region, when we're operating there, we're always putting pressure on those nerves. And again, like how I said, you know, if you blew someone's abdomen up with carbon dioxide for keyhole surgery, you're putting pressure on the bowel. If you've got contamination, so in patients where they've had something that's burst, for example, and they've got fecal material in the pelvis, for example, or in the bowel, again, it's as if the bowel's been touched. Okay, the bowel does not like being touched from the outside. And obviously, if we remove any of the bowel, that's also, again, it goes in line with the fact that we're handling the bowel. So basically, any kind of colorectal resection means that you are at risk of ileus. And it's not a complication as such, because I expect ileus to occur. I'm probably more surprised when my patients don't have ileus. How does it present? Like a small bowel obstruction. So they'll be really distended. You'll get a bleep saying, okay, they're vomiting. Or what probably, if they're an emergency patient, I probably kept an NG tube down and I've probably said, okay, aspirate off it every 4 hours. And then all of a sudden you've got this high NG aspirate. And the reason being, everything's blocked up. Nothing's moving through. And again, a lack of flatus. So if they've got flatus, it's probably telling you that their ileus is probably starting to move along. However, patients can also be constipated as well. That's why these patients on the whole need a PR examination, just to make sure there's not it's not just constipation. Now, if someone has a high temperature, you have to think about an anastomotic leak, and I'll talk about that next. But if they don't have a high temperature and all they're complaining of is abdominal distension with the vomiting, not really opening their bowels, you've looked at the opno, they're elderly, they're derangement in LFT, so in electrolytes, and you think to yourself, actually, this probably is likely to be ileus, then I think that's fair enough. Don't bother with an abdominal film. An abdominal film in surgery is mostly a waste of time unless a registrar or a consultant's told you to do it. Because if it looks like it's an obstruction, I'm going to ask for a CT, okay? And on an X-ray, you can't tell the difference between ileus or small bowel obstruction or large bowel obstruction. You can't tell. So that's why a CT is better. But you don't need to do a CT for ileus unless you're suspecting something else. So investigations-wise, bloods, correct the electrolytes, CT if you're worried that possibly something's gone wrong. And the treatment is nutrition, IV fluids. There's been lots of studies in how to prevent this from happening, and a lot of that is about aggressive IV fluids, and obviously my potassium. If I've nailed anything home or kept on it, it's about that potassium. Is continuing to get that right is actually early mobilization. So these patients being active, it just gets things moving. So sometimes you'll see, if you've read one of my op notes, I know they're really long, but you'll see that one of my things that I put down is mobilize. And I tell patients all the time that it's going to be painful when you mobilize because your tummy's going to be really sore. Take your pain relief, but the more you move, the more you prevent the ileus, because ileus has been shown in America to waste around 1.5 billion to their health industry, because patients stay in hospital for on average another 5 odd days because of it. So there are lots of studies trying to see how we can reduce ileus, but essentially it's fairly a benign condition. However, an anastomotic leak. So all of this I've kind of been building to this join I spoke about. So a lot of those operations have a join. Obviously the abdominoperineal resection or anything with a procto, there's nothing to join onto in a proctectomy, okay? You're going to have a stoma. If you can't join onto the anus, then you're going to end up with a stoma. But for those procedures where actually we're being able to join, okay, there's always a risk of an anastomotic leak. It happens between 5 and 15%. And for surgeons, we audit our data. It is the one thing that you don't sleep about. And if you come to theatre with me, and you're more than welcome to come and see some of these when I'm doing them or still developing and learning to do them, you'll really notice that in theatre we'll say, oh, we'll put an extra suture. We'll put an extra suture. That's your sleep suture, because ultimately you don't really sleep as a surgeon because you're always panicking that this patient can get an anastomotic leak. And there are some factors that are patient factors. There are some factors where actually it's just poor surgical technique. But regardless whether it's patient factors or surgical factors, most surgical trainees and consultants, we take it really badly. We hate complications. We are going to get them because that's what surgery is. Or you can't go swimming without getting wet. But an anastomotic leak is a recognized complication. Its most common time is 5 to 7 days. So when you're seeing that patient, you've read that op note and you go, oh, it's 5 days, then I want you to have in your head, is this an anastomotic leak? And normally what it is, it can happen before. I've seen these happen at 2 days. Now at 2 days, you do worry about the consultant or the surgical technique, because that kind of says it's a bit too early for that failure, but it does happen, even to the best of us. I've seen it happen. Your jobs are basically to keep an eye on this. And this is something where if you think someone's got an anastomotic leak, this is one where I definitely want you to bleep me, you know, and if I'm in theatre, then I'll tell you exactly what I want you to do. So the risk factors here are immunosuppressants. I mentioned it before, steroids. You want healing. That's what you need. When you've got a join, you want healing. Smoking, alcohol. Smoking reduces oxygenation to the tissues. You need oxygenation for healing. Alcohol, again, impairs your liver function. Diabetes, high sugars, again, impairs healing. Obesity, again, raises your level of diabetes. Equally, malnutrition. So people who are severely anorexic. So if you see some of the Crohn's disease patients, for example, one of the reasons that we don't like to operate on the Crohn's disease patients immediately is we try and bring them in, and sometimes you'll see them on NJ or NG feeding for 2 weeks, because we know that when their albumin is really low, actually, when we're going to join them, it's just going to fall apart. As I said, sometimes you can get a feel when you read the operation note. So if someone kind of says in the operation note, you know, challenging dissection in the pelvis, to me, that's a longer operative time. That's what they're telling you. That's the code. Peritoneal contamination. So if there's, when they've taken the bits out, if stool has leaked into the pelvis. And again, this makes sense. So in a rectal anastomosis, so if I go back, I'm going to go back here. And I talk about these low anterior resections. As I mentioned to you, the rectum and the anus, they're fragile places. So anywhere that's really low down, okay, by the sphincters in the anus, they're places which they're fragile. So you're at more risk of a leak. You may say, well, why bother doing this operation then? For the whole purpose that you're trying to save someone having a stoma for life, okay? Sometimes what we do is, we do this operation like a low anterior resection. We join this part of the bowel, the left side, down to the rectum. So we join it, but from the ileum, we take out what we call a diverting stoma. It's a temporary stoma. And the idea is, look, if you've got stool going all the way around, testing your join, your anastomosis, you could get some bacterial leakage, it could get infected. And actually, if you diverted that away into a stoma for, say, 6 months, allowed this to heal, and then you just basically put the stoma back and joined the bowel back up, then that may be a better way to do it. There's no 100% way which is better than another, okay? Ultimately, if you see the words anterior resection, it's likely they've had a join. Even if they've got a stoma, okay, they still can get an anastomotic leak. You don't have to have something going through here to have an anastomotic leak, because don't forget, the patient would have eaten beforehand and there'd still be stool in the bowel. So going back to anastomotic leaks, the presentation is basically how someone, they're tender in the abdomen, they're spiking temperatures, your typical RCC patient, because they've got abdominal pain and they've got a temperature. So investigations, ultimately, a patient like this, and you're thinking to yourself, look, they're tender. Yes, their chest may be a bit knackered as well, but if they're behaving septic and their abdomen, and they've had a colorectal operation and we're around day 5 or 3 to 7, you've got to be asking about, have they had an anastomotic leak? The treatment is still going to be for surgical stuff to happen the following day, okay? But in the meantime, save lives. So antibiotics, fluids, be aggressive with it. And ultimately, I'll probably be saying to you, look, I want a CT scan with IV contrast. And the reason I want contrast is because I want it to get all the way down to that join, and I want to see if it extravasates, okay? So if it goes outside of where it's meant to. a little play on words back to intravascular and extravascular. But if it leaves where it is, then I know that there's a leak, because really there shouldn't be anything. Treatment-wise, as I said, antibiotics, get a catheter in for these patients, because you really want to push their fluids to the point of just before overload, because these patients can get really, really sick really quickly. And if anyone kind of, and I really have a go at some of my F1s, and recently, when I say have a go, I was constructive about it, but they had made a comment to me when they came down for their break, where they were like, oh, I got called to see this septic patient, but when I got there, the patient was asleep and their temperature had settled. And I was like, oh, so what did the patient have? And they'd had a colorectal, they'd had an anterior resection. I basically said to them, so finish your lunch and then please go up, please go and take some blood cultures, go and review that patient and wake them up. Because actually that patient had an anastomotic leak that we found the following day on our nights. And the reason I say that is that when someone spikes a temperature, it's when their bacterial or viral load has overwhelmed the immunological response. It doesn't happen just for no reason, okay? In pancreatitis, it's slightly different, but in surgical patients, there's probably bacteria swimming around. So us giving paracetamol gives us an easier night, okay, and just reduces the temperature, but it's masking what's going on. So could it be an anastomotic leak? That's the thing that I want you to keep on asking yourselves. Thrombosis. So you'll probably be a lot better at dealing with this than myself. In colorectal patients, it happens between 1 in 100 to like 2 in 100. Okay, it's a lot more common than we realize. Again, you'll look at the limbs. You could have a cold limb. One limb's much bigger than the other, or it could be shortness of breath as well, and a drop in oxygen saturations. So anyone who has a drop in oxygen saturations, for me, always, if you're going to discuss this with me, I'm always going to ask you, what does the arterial puncture show? What does that blood gas show? Because ultimately, no one in a hospital should drop their oxygen saturations. The most common cause is probably a chest infection, but this is life-threatening. And when we operate in the pelvis for a lot of these colorectal operations, it increases the risk. If you ever look at those VTE forms in the blue clerkings, and you see about, should I be prescribing VTE to this patient, there's a big section about pelvic surgery, because pelvic surgery really does increase the clotting of the body, which means that you're increased risk of thrombosis. Again, investigations. So ECG, if they're tachycardic. And remember, like for a PE, I'm sure all of you know that the most common finding on an ECG is a sinus tachycardia. Sometimes you see a prominent S1, a Q3, T3, so T's inverted, arterial puncture, that low PO2. The moment you get a low PO2, and even if this patient's on oxygen, okay, I had one of my F1s say to me, oh, it's okay, because, they're at 10 at the moment. And I was like, oh, okay, are they on any oxygen? And it was like, yeah, they're on 5 liters of oxygen. If you're on 5 liters of oxygen and your PO2 is still 10 or 9, to me, you're still hypoxic, because why do you need that oxygen? So I treat that as a patient who's hypoxic. And to me, that's PE until proven otherwise. Chest X-ray. So the process, if you get a chest X-ray and it's normal, then radiology will do a CTPA for you. If you don't have a chest X-ray, for the simple principles that it's more likely they've got a chest infection, they won't do it, okay? So CTPA needs to be done. And I would say that if you suspect a PE DVT, give them dalteparin, unless it's contraindicated. And that's probably something that, if you don't feel confident doing that, it's a bleep to me, okay? 2615 at night, I'm very happy to have that discussion. And if you ever want me to see a patient, you just know, just 2615, I'm very happy to come and see that patient and make that decision. But ultimately, we want to get to this level. So even if we don't have that CTPA, sometimes what I'll say to people when you're assessing these patients, look, listen, this could be, because obviously you're going to take bloods off as well, this could be a thrombosis, this could be a chest infection. Let's treat for both. So hospital-acquired pneumonia, we'll give them tazocin, and if there are no contraindications, give them dalteparin. We can't go back in time to save lives, And I think that's the thing, that with surgery, you're never really going to go wrong if you're aggressive in your management, but you're using anatomy and physiology, you're being as safe as possible. And I want you to commit to decisions. And I'm really happy for you to talk to me about, I want to do this, what do you think? Because that will build your confidence. And that's exactly what all the SHOs I'm with, what the F1s, that's what they do. And I don't see why you should be any different, considering the fact that some of you have known me since I was here in 2016. That's your S1 Q3 T3. I've seen this only once, so it's a bit of a waste of time. But sometimes if you're on a medical ward round, they quite like this question. So you can see the S wave there is prominent. When you're looking in lead 3, you see the Q wave, the first deflection down, and you can see that the T is inverted. So infection, and these are things that I think that I really do expect you to really do this really well. And when it comes to chest infections, I think every single one of you that I've encountered have been just completely 100% a star. Like, the management is absolutely perfect. I have had some of you just get a bit nervous about wound site infections, and I wanted to talk about that. So 3 to 30 is huge, the variation. Now, a lot of these people have midline, lower midline laparotomy incisions with clips. It's beautiful when you see clips, because clips can be removed. Now, what sometimes happens with this is patients will have signs of sepsis. When you go to examine them, their whole abdomen is not rigid, okay? When you actually look at their abdomen, what you tend to find is erythema. And when you touch the erythema, when you blanch the skin, you put pressure on that erythema, on the redness, you'll see that it blanches white and then goes back to being red. That's kind of what you see in cellulitis, and that's essentially what this is. When you get a wound site infection, it tends to be cellulitis. But what's going on is underneath that closure, there's a collection. And like how patients need to have a drainage of an abscess, that's essentially what this is. So I look for where it looks like the wound may look like it's closed, but sometimes that wound is just going to open up. And if you're telling me over the phone, say, look, G, I've seen this patient, there's erythema, it's blanching just like you told me, it's a bit firm as well, they've got a temperature and their heart rate's up, I've given them antibiotics, I've given them fluids, I've done everything as you would have said for me to do, but I think there's probably a bit of a collection there. Then what I want you to basically do is get a clip remover and remove some of those clips, maybe 3 or 4, maybe a bit more. If it's already showing that there's some fluid or some pus coming from that wound, open it up. Yes, it will fall apart and open on you, and you'll be like, oh my goodness, what have I done? What you've done is you're helping save a patient's life, okay? And if they develop wound site infections, their risk of getting an anastomotic leak is higher because they've got a higher bacterial load. So again, you're treating this patient. It normally takes a few days to come about. And again, that's the erythema, and that's my little test. I kind of prod a little bit with gentle pressure, and you see it blanch and then go back to being red. In terms of chest sepsis, my little trick, I know all of you know that I go around with a stethoscope. It's because the majority of my patients 1 in 5 are going to get a chest infection. People I operate on, 1 in 5 are getting a chest infection. So I better be able to treat it early. So dull percussion when you percuss, and increase vocal fremitus. So my trick is, if I think it's dull in a certain area, stick my stethoscope on there and I just say, whisper 99. And you should hear it just boom in your ear. And if you can't, if you're just hearing it really faintly, then you pretty much know that's unlikely to be consolidation. They still could have a lower respiratory tract infection, but that's always been when I'm never sure and I think, oh, could this potentially be overload? Actually, if it booms in your ear, that's consolidation. Investigations. So your sepsis 6, your chest x-ray, your bloods, your pus swab. Get me a swab of that. And what I tend to do is I tend to take the clips out, take a few clips of the wound out. Don't take all of them out. Take the ones that look the most angry and where this redness is. And then with the pus swab, I push the pus swab into a hole and I just sweep it up and down to kind of open that up a bit. And again, if you don't feel confident doing it, bleep me, we'll do it together. And then the next time, bleep me, you can do it. And then all of a sudden you'll know exactly that actually it's a very simple procedure. Taking an ABG is a lot harder. Treatment, again, sepsis 6, wound site is removing the clips. So
Gee, can I just interrupt you? Sorry to interrupt you. It was
Apologies,
just a question.
yes.
It was just a question from Erin on the previous slide. She's just asking with regards to the thrombosis patients. So she noticed that the D-dimer wasn't actually on the list of investigations there, and she's just asking, you know, would you expect it to be raised post-operatively anyway? Is that the reason?
And that was Erin who said that, was it?
Yeah, that's right. Yeah.
Erin, that's an excellent question. Okay, that's a really, really good question. So on medicine, D-dimers are really important. Okay, in surgery, I'm just going to go out and I'm going to say it's a waste of time. And the reason is, in colorectal patients, in surgical patients, all surgical patients should have some element of infection or something that's going on. Okay, so ultimately, those patients are patients who are going to test positive on a D-dimer. Now, yes, I know there are some of the surgical patients who are the little old ladies, the little old men who are lovely to speak to, who've been there for like 20, 30 days, and they're at risk of thrombosis, but they're medically fit for discharge. We just can't get the social stuff sorted. And in those patients, you could do a D-dimer, and that could be negative. Most of the patients you'll see will be at night, but even if you come and do some of the days, and some of you may want to take on the nightmare of dealing with like being part of the team on surgery in the days, okay, a lot of this is the acute nature of this. Pelvic surgery means that you're just so much more at risk of that, and waiting for that D-dimer to come back, it could tell you, okay, well, look, it's negative, and the chances are, if it's negative, then we're going to say, well, it's unlikely you've had a PE. But if it's a chest infection as well, so if you're not sure if it's a chest infection for that drop in SATs, then actually that D-dimer is going to be positive anyway. So you're going to be left in this place where it's like, well, okay, I've got this. My thing here, Erin, and for everyone else, is that drop in SATs is one thing. That's the trigger point. The gas, if the PO2 is down, I'm asking why. And it could be a chest infection, or it could be thrombosis. Okay, so it could be a PE. Ultimately, I can go back, I can stop the dalteparin tomorrow. I can do that. But it just delays. It just delays your diagnosis. And yes, I know, look, it'll come back in an hour, but it's just slightly different with surgical patients. So a D-dimer is valuable, but not in this scenario. But equally, if you're not sure, you can have that discussion. But that's why I didn't put it down there, because I think the blood gas, the drop in SATs, to me, it's PE until proven otherwise. Does that make sense, Erin? And everyone else?
Thanks, G.
Yeah, okay.
Yes, it does. Thanks, G.
Yeah, okay.
Can I just ask as well, G, you know, when you're talking about infection, you'll get quite a lot of patients that are rang through with a temperature. They've been sort of maybe like 6 or 10 hours post-op, and then I've had a lot of feedback where people said that it's unlikely to be an infection so soon after having surgery, and I just wondered, I guess it's different with different types of surgery, but I just wondered what your take was on that.
Okay, so that's a really, that again is an exceptional question, okay? So that's a bit more of a challenge, and what I'll tell you is, for most colorectal surgery, for 24 hours, you probably say that you expect what we call a post-operative pyrexia. Now, what happens is when you operate on someone, you move fecal material, you move bacteria. We call it bacterial translocation. Basically, it's gone from one location to another. And that's basically, in colorectal surgery, that's what you're doing. You're moving bacteria from one area to another area. There's the inflammation of just cutting something out and putting it back together again. So we call it a SIRS response, systemic inflammatory response syndrome. So what that basically is that's your body's way of basically, it's its response, and it's a heightened response. And it's common to get a post-operative pyrexia, okay? But equally, you've A to E'd that patient. And if you A to E that patient and you say to me, gee, look, listen, I know it's like 6 hours, I know it's 12 hours, it could be just post-op pyrexia that you accept. But I've examined that patient, I've listened, and I think that the right base is dull to percussion and it's booming in my ears that it's 99. Then to me, and their SATs have dropped a little bit as well, to me, yes, it could all be anesthetic related, but equally, that for me is a reason to treat. So I would always say that yes, in the first 24 hours, sometimes people will lose 48 hours. Sometimes consultants will have a go at you, and they've had a go at me, and they've said, gee, this is ridiculous. Come on, you're a surgical doctor, you do this operation. Why are you giving my patient antibiotics? You know, you should know this is just a SIRS response. I never give it just purely based on, okay, they've just got the pure pyrexia. I know I've just gone on about how sepsis 6 saves lives, but equally with a pancreatitis patient, it's a similar thing. So when they've got pancreatitis, I expect them to have a high temperature because they have that SIRS response. But I don't give them antibiotics for it unless I've examined them and I think that something else is potentially going on. So it's a really good question. And what I'd say is that whatever you do, if you're able to justify your thought process, and that's what I'm really big on. I don't treat you as someone who just does an A to E. I treat you as very highly skilled individuals. So if you sell that to me, that you think it's this for this reason, then I think that's completely appropriate. It is common for patients to have a pyrexia, have a temperature after an operation for 24 hours for that bacterial translocation, especially with colorectal patients.
Thanks, G.
Okay. I'm conscious I don't want to go too far over time. I've got a couple of slides left. Are people happy for me to finish those? Again, if you want to tap out, I'm not going to be offended.
Yeah.
Yeah? Okay, all right. So ischemic gut. So essentially, we do everything with the plumbing, but when we put everything together, and I'm going to just go back just to give you a bit more of a visual representation. So when we take out this, so let's say, for instance, I take this bit out and I plumb it onto this bit of the rectum. When I do that, this is also attached to a blood supply, okay? There's fat that's involved here, and in that fat is what we call a mesentery, and that's got a blood supply to it. And I basically, from here to here, I have to control that blood supply. So I basically tie lots of little knots on the blood supply all the way down, basically. So therefore, there's no blood supply. So when I actually cut this out, I don't have tons of bleeding. I then plumb on the healthy blood supply to the blood supply at the bottom. Now, even with the best of intentions, sometimes you can accidentally have knocked a bit of the blood supply, or maybe this is a patient who has hypertension, AF. Okay, they've got all of these risk factors for like throwing off strokes and clots. That is also going to make them have a high risk of developing ischemic bowel, ischemic gut. Now, after an operation, if it's very early, you have to think about surgical technique, because ultimately anything that happens within 24 hours, you have to say it's more likely operator error. But ischemic gut, it's a rare complication, but when it happens, it is life-threatening and it needs to be identified really early. So going to that, essentially it's decrease in blood supply. The risk factors for it, as I said, basically ischemic heart disease, again, a long operation, because a lot of this is a clot could have been thrown off. So again, that goes in line with that thrombosis and people with AF. So when you go and see these patients, you examine their abdomen, you get your blood gas off, you see that their lactate is high, okay? So then you're starting to think, okay, their lactate's high, this could be sepsis, but in the back of your mind, you're also thinking, but they've had a colorectal resection or a small bowel resection where one of the surgeons, they've messed around with the blood supply a little bit. You've always got to be thinking right in the back of your mind. So you've got your anastomotic leak, behind that is ischemic gut. And if you then go and look up the risk factors and go, well, actually, this person's a bit of a vascular path. They've got stenosing of their vessels. They've got AF. Start thinking in the back of your mind: is there some gut in their tummy that is dying? And again, they'll have generalized abdominal pain, but it's completely out of proportion. So anyone, if you go and examine patients now, and you go and examine patients that you think of ileus, they've got this like pain from like the pressure, but it's not horrific where they're dying. When you examine a patient with ischemic gut it's been there for a while, they're starting to get peritonitis, inflammation underneath the peritoneum. You've got your skin up here, the peritoneum, and they start getting this pain where literally the nurse has told you they've given them like 20-30 milligrams of morphine. They keep on asking for it. They get some nausea, some vomiting. They start looking really flushed. They've got pallor, really pale. That's when you want to start thinking, okay, hold on, I've read this op note. It was a prolonged operation. It was challenging dissection in the pelvis, something like that. Okay, that's telling you it's a prolonged operation. Investigations at lactate. So if you've still got that high lactate, you've to eat them. The chest sounds all right. You're not concerned about the chest. You look at the wound. The wound doesn't look like there's a collection. It's probably early on in, it's probably like day 1, day 2, post-operatively. And what you want is, you want a triple phase CT, because what it does is it allows for an arterial phase, because ultimately I want to see if there's any blood supply getting to that part of the gut. And that's going to tell me whether I need to take this person back to theatre. So if someone has ischemic gut, you're taking them to theatre within an hour, because that will spread and they'll die from that. So it's one of those things that it doesn't happen very often, but it's so, when it does, you really do know it. It's a presentation you don't forget. And again, that lactate is high, and sometimes you've got to come back and do a serial lactate. Well, you'll examine that patient, go, I'm not sure about that. I'll come back and see them a bit later, and their pain is exactly the same. That's the time to kind of escalate. And obviously their bloods as well. Again, you treat them with a sepsis 6, get a catheter in, get fluids, aggressive fluid management. We talked about that intravascular space. Fill that intravascular space, get fluid to the heart, get the heart to pump that around, get that blood pressure up, and then basically escalate. If you think it's this, it's a completely fair escalation to the SBR on call. And for something like this, if you feel, you can always call me in theatre. I'm never so busy in theatre that I can't answer a call. So you can always call me in theatre. Other registrars may be slightly different, but you will work with us. You'll know which ones you can do that, which ones you can't. And my final slide really is urinary dysfunction. So colorectal surgery, basically, when we operate in the pelvis, we always have to try to find the water pipes, the ureters. They connect the kidneys to the bladder. Sometimes we damage them, but the nerves that go alongside, we damage those as well. So if ever anyone that you know has had colorectal surgery, we tend to tell them about erectile dysfunction, decrease in libido, because all of the nerves down there are where we go near, and you can't control all the time because everyone's anatomy is different. So it's really common for some of these patients basically to end up being confused, urinary retention. They can also have, it really is a rare event to damage the ureters, the water pipes, because when you do that, it's a nightmare trying to repair this for this patient. But they tend to get pain in the flank, so around the sides, and you'll know if it's a right hemicolectomy, the operation's on the right side. So if they're getting, if we've damaged, we wouldn't have damaged the left ureter because we wouldn't be anywhere near that. So it's likely that they could end up having like a flank swelling. So you feel it there and it's swelling. And what that is, it's just pooling of urine, basically, because that urine is extravasating. It's leaving where it's not meant to. They can have an AKI, hematuria as well when you do a dip. Investigations for this is a urine dip. Again, other things with dysfunction, these patients get urine infections, get them a bladder scan, make sure that actually the bladder's not full or that there's a clot there that potentially just needs to be flushed through, and a blood urea nitrogen level if you're suspecting a ureteric injury. Again, these are rare. In my 5 years on and off at being in the Northern, I've not seen one. That doesn't mean that my next shift I may not see one. So it's just, again, something to keep in the back of your mind. And if there's a drain that we've left in the pelvis and it looks kind of like urine, you can send that off for a creatinine just in case there's urine that's leaking in there, because that patient's going to get really sick really quickly. They need urological intervention. And again, treatment, the treatment stuff, all of you pretty much will nail this down, because you do your sepsis 6, you know, with your eyes closed. And then pretty much, I always want a catheter for most of these patients. And again, if you're concerned about a ureter injury, it's escalating. So just to recap on everything that we've kind of spoken about. So really, honestly, read the operation note. And I know sometimes you look at it and you'll see some words that you don't get. I don't get them either, okay? A lot of us have a different style in the way we write, but you can tell from how much is written whether it was complex or not. And complexity normally adds up to length of time. It's a bit like when your friends kind of answer a question in a certain way, you always kind of know there's a bit more of a story. And that's what an operation note tells you. Pelvic surgery, so most colorectal surgery, you're going to be in the pelvis. So always think about those nerves we can damage, those ureters we can damage, those anastomotic leaks. And again, has the patient had an anastomosis? Now, as I said to you, some patients, you know, as long as their rectum and their anus hasn't been taken away, they'll probably have a join. They may have a stoma. You may have gone to see them and you've seen a stoma, but they've probably still had a join. So if they've had if they've had an anterior resection, they've had a join, even though they've got a stoma. So don't just assume that you see a stoma and you go, oh, well, okay, well, actually, that stoma basically means that they don't have an anastomosis. So one of the questions that you always want to, when you're communicating to a registrar and things, be like, oh, they've got a colonic anastomosis, or they've got an ileocolonic, ileo for ileum, to colon anastomosis. Could it be an anastomotic leak? Remember that day 5 is the golden time. We all kind of sleep up until day 4, and then we don't sleep waiting for this patient, whether they're going to have a leak or not. Thrombosis, again, as I mentioned before, look, I think a D-dimer in these kind of acute patients don't have the value that clinical decision making with that low PO2 and a normal chest X-ray. So low PO2 and a normal chest X-ray, to me, is definitely a PE until proven otherwise. Infections, as I said, chest infections we've spoken about, and also just those wound infections. You'll be really surprised at how much of a difference just opening up a wound can make to a patient. Ischemic gut, that persistently high lactate, that pain out of proportion, associated with those kind of vascular type of risk factors. So patients who've had vascular operations, although I know this is all about colorectal surgery, those vascular patients on Firth 2, they have a high risk of developing ischemic gut. And then urinary dysfunction, as I said, and that can be whether there's a ureteric injury, or it can just be the fact that they've gone into retention. They're high risk as well for getting urine infections. So basically, does anyone have any questions?
No, I haven't got any. It was really good, that.
So you're all welcome to shadow me when I'm on call. Some of you have actually come to actually spend time with me on SAC, clerking new patients, seeing different sides of the work that you kind of do, because sometimes some of you are always on the nights. So you're more than welcome. You know, we just have to arrange it so that it's a good experience for you. I don't want you just to kind of come along and you just get a terrible experience. So if you do want to do that, you know, my email address is there, and I'm more than happy, because for me, when you're there, you're actually help as well for me.